Okay, presenter is Melanie Desapri. She has committed to over 20 years to Rainbow Babies and Children's Hospital and is currently the lead clinical nutritionist for the Congenital Heart Collaborative here at Rainbow. In addition to her role at Rainbow, she is a community nutritionist for children with medical handicaps, where she conducts home visits for high-risk medically complex children across Northeast Ohio. She has professional memberships to the Academy of Nutrition and Dietetics and the Dietitians in Nutrition Support Practice Group. She has authored multiple publications and lectures with involvement in numerous media appearances. We are honored to have her present today. Please welcome Melanie Desapri.
Okay. Of you, so it's kind of freaking me out. So yeah. When Brandy asked me to do the presentation, she wanted like infancy to the big span. So it might be kind of basic, but I tried to go through everything. And this presentation is a big compilation from all the dietitians over in Rainbow. I took all their presentations and kind of put them together, so they all get credit. But basically today I'm going to talk about the assessment of malnutrition using the nutrition-focused physical exam, discuss appropriate feeding for infants, toddlers, and children, discuss how to optimize PO feeds when poor weight gain occurs, discuss when oral feeds and TPN are appropriate, make referral to a nutritionist, and how to find reliable nutrition resources. Components of a nutrition assessment are anthropometric measurements. They're really important to get accurate measurements because we're diagnosing malnutrition based on these measurements. Biochemical data, medical tests and procedures, getting a good food and nutrition history, getting a client history, what we find on our physical examination findings, and then estimating energy and protein requirements. Obviously, we screen the screening tool for assessing nutritional status. There's the Fenton growth curve for premature infants, plots 22 to 50 weeks from the 3rd to 97th percentile. The WHO charts are from birth to 24 months. I know sometimes floating out there, there's still birth to 36-month growth charts, so do not use those. Some of my home visits, some of my pediatricians that are way out there, I'll still get these birth to 36-month growth charts. So those have been gone for 10 years. The CDC growth charts are for 2 to 20-year-olds and go between the 3rd and the 97th percentile. So this just shows you an example of the Fenton growth curve. You're looking at recumbent length. You're plotting weight for age, length for age, weight for length, and head circumference for age. And obviously, it's reflecting the growth patterns of healthy breastfed infants under favorable conditions. Usually, an infant establishes a growth pattern during their first year. The birth to 24-month growth chart. So, in the sense of the length for age is less than the 2nd percentile, and the weight for age is also less than the 2nd percentile. The difference is also less than the 2nd, and then weight for length was less than the 2nd percentile too. This is weight gain during the first year, so that's the most important time of growth. We say that a child should double birth weight by 4 to 5 months, triple it by a year, and grow 50% in their length during the first year. So this just gives you some good. C growth charts, so you're using standing height, you're plotting the weight for age, height for age, and BMI. The CDC growth charts are either the 5th to 95th or the 3rd to 97th percentile. One, you're looking for a growth pattern and investigate when height and weight are less than the 5th or weight is greater than the 95th percentile or some sort of pattern change. 15-year-old is 160 centimeters, 6 kilos. And then so to figure out desirable body weight, it's the times their height in meters squared. That's how we figure out a desirable body weight. So B is underweight and overweight. It's used for ages 2 to 20. So 5th percentile is underweight. 5th to 15 is at risk for underweight. 85th percent is a healthy weight. 85th to 95th overweight, greater than 95th obese. And you'll see sometimes like it'll look, someone's got a high BMI and then you go in and they're real muscular, or you know what I mean? So obviously you always need to lay eyes on the patient. That's the most important thing. Special growth charts. So these are just a list of some of the special growth charts that are out there. So it used to be we'd look at percentiles and we'd say, oh, this child is between the 10th and 25th percentile, but now looking at Z-scores, which were formerly used in research. So the number of standard deviations away from the mean is what it is. Percentile corresponds to a Z-score, used in research, and it standardizes the assessment of undernutrition. And PD Tools, I don't know if most of you use that, that's like my best friend. So PD Tools is a great resource for plotting kids. I used to carry on my growth chart in my pocket and all of that, so now PD Tools, and you can really say where a child is. So what it like. So you can do a lot on here. The percentile and Z-scores. Basically, the 50th percentile is 0 score. So just kind of looking how that goes. So what we do for assessing malnutrition. So typically, things we look at are weight for length, if they're birthed to 24 months, or their BMI. So if they're other things that we look at as well, but milder at risk would be like a -1 to -1.9 Z-score. Moderate would be like a -2 to -2.9. Severe would be greater than -3. Like I had a kiddo yesterday, his BMI Z-score was like -8.74. Clearly, he's severely malnourished. So history, getting current past medical surgery history, medications, vitamins, minerals, herbal supplements. People are taking all kinds of things these days. So really finding out what they're taking, where they're getting it from, how much they're taking, have them bring in the bottle so you can see is important. Getting a social history and psych history. And the data, so there are different labs that we may look at. And then a nutrition history. So it's being a private investigator, so you have to ask questions sometimes in many, many different ways. You want to find out who the caregivers are. So you might assume this is mom, it might be grandaunt, whomever. Find out who's taking care of the child. Is the child with multiple caregivers? Maybe having them like keep a record and passing it with the different members that watch the child. So have they had change in appetite or intake? Any GI symptoms greater than 2 weeks? Allergies, are they on the WIC program? Getting a typical day's intake, and then possibly observing a meal or feeding. That can tell a whole lot about a child. Components, so if the child is breastfed, trying to find out how many number of feeds, what's the length of feeds, are they supplemented with anything? They're formula fed, what type of formula, how many feeds a day, the amount a day, how are they preparing it? We'll get a lot of kids in the summer, especially with hyponatremia, so maybe their formula's running out at the end of the month and they're diluting their formula. Some kids might be they're mixing it improperly, putting typically powders like 1 scoop per 2 ounces with most formulas. We'll see kids getting 1 scoop per 8 ounces, or they're just putting too much formula, not enough water, and kids are getting I've had kids getting 60 calorie per ounce formulas, and they are typically 20. So finding out exactly what they're doing. Getting water, juice, coffee, tea, who knows what's in those bottles. So just finding out, too, what they're drinking. And don't ever assume. I had a 4-year-old ago, and I'm assuming, like, you're not on a bottle, but yes, indeed, she was still taking a bottle, and they were 11-ounce bottles, and she had a hemoglobin of 3, and Mom told me 3 bottles of milk. I usually double what they tell me, so it was probably explaining why her hemoglobin was 3. And then frequency, timing, location of meals and snacks. Are kids walking around and eating? Are they sitting at a table? Are they sitting in front of the TV? Where are they eating? What adequacy of intake? Is it adequate? Is it inadequate? Hypocaloric? Is it inadequate starvation? Not taking enough? Are they getting fed too much? We have a lot of kids that also may be overfed. I'll have kids that are a month old taking 8 ounces per feed. So if you set a full-term baby size is the size of a golf ball, you might put 8 ounces in, but it might not stay. and stressors that we'll look at for our assessment. And then focused physical assessment, we're looking at fat stores, muscle wasting, edema, and functional status. So I tell people I became a dietitian because I really enjoyed nutrition. I enjoyed working with families and people. I wanted to do pediatrics. I'm glad I didn't have to touch the patient or, you know, do all those things. And now it's amazing because doing the physical assessment is, you know, you're pulling away the blankets. You're looking at their hair. You're looking at nails. You're measuring their circumference. You're really taking a good look. And you often notice things that others may not notice. So it's just good. Impairment, we're seeing, do they have an impairment? Are they having difficulty with normal activity? Are they confined to a bed or are they bed bound at baseline? Upper arm circumference is another thing that we look at as far as assessment goes. It used to be every Monday we would get a free albumin, and that's what we would look at to assess nutrition status. And so that's been gone for a while. So something that we're really looking at is mid-arm circumference. So you can use that with the PD tools as well, and it really helps to diagnose malnutrition. So kind of, you have a patient to face away from you, bend their right arm at 90 degrees, elbow, measure the chromium process to the head of radius, and then averaging your two measurements. And this is malnutrition. So will patient malnourished? Is it illness related or non-illness related? Disease, injury, inflammation. If it's non-illness related, is it environmental and social, which a lot of times that can be as well. And chronic. So is this, we usually acute is less than 3 months and chronic is greater than 3 months. So acute, weight is affected, wasting, chronic growth is affected, and stunting. So a lot of times if kids are chronically malnourished, they might look like they're proportionate to themselves, but they really have kind of failed on the growth curve. This is an acute malnutrition. You can see this child was weight along the 50th percentile and then it dropped. More of a chronic malnutrition. So you can see they've just been kind of, but if you plotted them, and that's, if you plotted their weight for length, you might say, oh, they're at the 50th percentile, but where should they have been growing if they were following their growth curve? And this, well, it's not that hard to see, but this just is a consensus statement of the Academy of Nutrition and Dietetics for parental nutrition. It's an indicator recommendation of identification of pediatric malnutrition. So these are just things that look at criteria that we'll look at to diagnose malnutrition. So our diagnosis of malnutrition in the hospital, I think we'll carry this over into their note, and they're getting reimbursement based on our diagnosis. So you want to make sure that you're having the accurate measurements. So it's very important. There are RDA for calories and protein. And then protein for maturity, so this just goes over birth less than 1,000 grams, 105 to 115 calories per kilo, 3.5 to 4 grams protein per kilo enterally, and then up to 130 to 150 calories per kilo enterally. And then birth weight, if it's 1,000 to 1,500, 90 to 100 parenterally, 110 to 130. So these little kiddos need a lot of calories and protein per kilo and fluid. Calorie needs. So these would be different. Chronic lung disease, a prematurity, CF, congenital heart defects. A lot of kids need greater than 120 calories per kilo. GI disorders, malnutrition, burns, and fever. So I slides just on how we add calories for different diagnoses. So fevers, you can add 12% for each degree. We might for CP, Down syndrome, spina bifida, and Prader-Willi syndrome. And then for CP, if the height is known, this is what we'll use depending on how much they're moving around. As some kids, they're just moving all the time. Once you're really watching them, you understand a ton of nutrition. And then for them, and spina. Willie. So how to catch up requirements. Basically, we plot length height and weight and determine their weight age, determine their desirable body weight. And we'll take the cows per kilo for weight age, multiply their desirable body weight, and divide it by their actual weight. And do the same thing for protein. So that's kind of how we figure out catch-up calories to get them where they should be. So obviously, human milk is the preferred source of enteral nutrition for all infants, including premature and sick newborns. AAP recommends exclusive breastfeeding for about 6 months with continuation of breastfeeding for a year or longer, as desired by mother and infant. So the pro milk is a whey-casein ratio. The whey is known as lactoalbumin. Milk is whey-to-casein ratio is 60-40, cow's milk 80-20. So obviously, infant formulas have been modified to resemble human milk. Of note, whey protein is different from bovine whey, and the protein content of human milk is higher in preterm and higher in hind milk. So no matter, I've heard people say, oh, if you follow a lactose-free diet, Mom, then your child won't get lactose. That's not true. No matter what, they're going to get lactose through your breast milk. Increase intestinal lactase activity. Preterm infants' levels of lactase are low, but they can readily break down the lactose in breast milk. 50% of the total calories. Fats made in the mammary gland. Production is stimulated by entering the breast and prolactin secretion. Content of human milk is higher in preterm milk and higher in hind milk. And assessing the adequacy of breast milk, breastfeeding. So adequate fluids and calories. We want to make sure, obviously, the child's having at least 6 to 8 wet diapers a day. If the baby's only having 1 wet diaper a day, that's an indication they're not getting enough. Bowel movements. Some breastfed babies have bowel movements with each feed. Nurse to 12 times a day, about every 2 to 3 hours. Being satisfied after feedings, and then a waking of a half an ounce to an ounce a day in the newborn time is what's expected. Some kids come in the hospital, we'll have moms put the baby, we'll weigh the baby, have the mom change the diaper, and then have mom put the baby to breast, and weigh again, leaving the diaper on. We always say what happens in the diaper stays in the diaper until we weigh. And a lot of you can subtract. Not completely accurate, but it's a good indication. So you'll get some babies in, and moms will be thinking that they're getting enough breast milk, and when you weigh them, they're like 5 grams more, which means they're only getting 5 ml of milk. So that's when you might talk about supplementing. Or you might see the child is getting a lot, but maybe they're not, maybe the milk's leaking and they're not latching on, all that. So it can give you a lot of information. Feeding strategies, early initiation of breastfeeding and adequate breastfeeding based on infant feeding cues, avoiding bottles and pacifiers for the first 3 to 6 weeks after birth, and appropriate follow-up with a pediatrician. Okay, formulas. So the standard infant formulas will be your Enfamil, your Similac Advance, and then your Gerber Good Start. The Gerber is 100% partially hydrolyzed whey protein, although it's not hypoallergenic. And I'm sure most of you know that 2 years in October will be the Ohio WIC contract, got Nestle. So most of our kids that were on the Abbott and Similac products are now getting the Gerber products. So lots of, Walmart has a brand and Target has a brand, and the different stores have a brand. Infant formulas are regulated, so if parents are buying a Target brand or Walmart brand of formula, that is fine, and that's much better than them getting cow's milk and goat's milk and everything else. So, are your Similac soy, your Pro-Sobi, Gerber soy, appropriate for galactosemia, primary lactase deficiency, or infants of vegetarian moms. So soy protein and cow's milk protein allergies, they can coexist. So a lot of times if a child has a milk protein allergy, they'll be told to also avoid soy. Higher amounts of protein in formulas containing cow's milk protein because it accounts for the low biological value of soy protein. Not recommended for premature infants. The fights in soy interfere with calcium and phosphorus absorption. So, your tolerance formulas, so you have your lactose-reduced formulas like your Enfamil Gentle Ease, your Sim Sensitive, and your Gerber Soothe. Your WIC you can no longer get Similac sensitive. So I know a lot of our NAS babies getting Sim sensitive, they can no longer get that from WIC. I believe they Genoese, and then Gerber Soothe is the formula. The carbohydrate is corn syrup, solids, and sucrose. Second formulas, so your Enfamil AR or your Similac for spit up. It's a rice starch added to thicken the product, indicated for reflux, and we'll have really good results with these formulas. The thing is, you can't really concentrate these formulas because it becomes like a brick. So I know with some of them we've gone up to like 24 cal. Sometimes you have to make it by the bottle if you do that, because if you make a date supply, literally it's a brick. So the kids can't take it. So my elemental formulas. So formulas with enzymatically hydrolyzed casein like Alimentum is 33% of fat. Nutramigen it's protein, but it's 100% long-chain triglycerides. Progestamil, 55% is MCT oil. And tyrosine added as they decrease during the hydrolysis process, and all or hypoallergenic protein is the casein hydrolysate. So the one thing about Alimentum has a powdered and a ready-to-feed. Alimentum ready-to-feed is one of the only corn-free. It's made with a tapioca starch. So we just recently had a kiddo in the CTICU. We had first on NeoSure, then we put on Alimentum 24, and we put on Elacare 24, still stooling. We put on Alimentum 20 ready-to-feed, and he's doing a lot better. So formulas. So your Neocare, Elacare, Pyramino, Alphamino. Kate's Nutritia, 100% free amino acids, 33% of fat is MCT. Elacare, 100% free amino acids, 33% is MCT. Your Pure Amino, Mead Johnson, 100% free amino acids, 33% of its fat is MCT. And then Alpha is Nestle, they have 43% MCT oil, 100% free amino acids. Kids do better, some kids do worse. Some kids might stool more with the MCT oil, so it just all depends. Indicated for infants with multiple food allergies who do not respond to casein hydrolysate formulas. They're very expensive. They don't taste good. So really should only be used with failure of other formulas and when medically indicated. There's formula, your PM6040. And we have like kids that are on PM6040, so it's not just infants. Some kids are on it longer. You can just concentrate it to a 30 cal per ounce. For infants who would benefit from lower mineral intake, including those with impaired renal function, the mineral levels are approximate content of human milk. It's a 60-40, that's where the 60-40 is from, ratio of whey to casein. Evidence suggests that whey protein may promote more rapid gastric emptying than casein. It's the only formula that's low iron, so if you have a child who's getting PM6040, you want to make sure that they are getting an iron supplement because there's no iron added to the formula. And then the thorax goes. Pathophysiology is a manipulation of thoracic duct during surgery. Leaks into the pleural space, causing the respiratory distress. Nutritional implications could be long-chain fats may increase the chyle output and cause high in protein and potentiates protein malnutrition. So we use some will skim breast milk, or they meant that they can skim it and then taking all the fat out. That would be cool if we had that. We don't. So we typically will use the Empaport or Monogen. Empaport comes ready to feed. It's 30 calories per ounce, comes in little bottles, so you just want to make sure that you are diluting it. And especially like a lot of kids that are getting a newborn, so our formula will make it, and they'll make it down to 20 calories per ounce. And if we have to concentrate, make it higher, we will. And then the Monogen is a formula from Nutritia. They're both milk-based, so if you have a child that can't tolerate milk, then we'll have to use other formulas that might not be as high as an MCT, but will be milk-free, so they'll tolerate it. Like we've used Pediatric Vivanex in the past. Not often. It's really recommended for kids over 1, but we've had to use it. Or maybe we'll use Progestamil. It's not an amino acid, but it's higher in MCT, so just kind of looking at that. Indicated for less than 1-year-old when lactation is not chosen. Iron fortified formulas. Formulas, like I said, are standard soy, protein, hydrolysate, elemental, or free acids. You want to allow about 15 to 30 minutes to finish a bottle. So if a child's taking an hour or 2 hours to finish a bottle, definitely a problem. This shows you the normal volume of bottles depending on age. I get asked that all the time. How much should they be taking? So this will give you some as far as that goes. As far as introduction of complementary foods, AAP recommends around 4 to 6 months of age. WHO recommends 6 months of age. Added benefit, less than 4 months of age. Obviously, if kids are premature, you want to do it when they're corrected to the appropriate age. And then readiness assessed on individual basis. So a lot before they age, kids' tongues are going like this. They're not really ready to take a spoon. You want to make sure that they're able to lift their tongue, maybe hold their head up on their own, not necessarily sitting up, but holding their head up on their own. This just goes through developmental milestones for solids, so gross motor and oral motor development, so head control, coordination of lip closure, ability to transfer food from the front of the tongue to the back, ability to swallow, soft, solid foods, sit with support independently, show desire for food by turning towards it, leaning forward, opening mouth, and showing satiety or disinterest by turning away or leaning back. So you never want to force feed, or some parents hold the children's mouth and put the spoon in it, and you want it to be as pleasant as possible. So developing good eating habits at a young age is good, so it makes it easier later on. Don't have schedules too, so figuring out a schedule as far as, okay, a breakfast, a lunch, a dinner, so offering single ingredient foods one at a time, we usually say for the first, for 3 to 5 days each, making sure that they're not having any rashes or hives or diarrhea or any adverse vomiting reaction. Meat, fish, poultry, heme iron and zinc, soups, non-heme iron, vegetables, fruits, and other items. Usually takes 10 to 20 trials with new foods and a teaspoon to a tablespoon. So you want to introduce foods when kids aren't starving, but when they're not full. So somewhere in between, making it as positive as possible. And try to booster seat something that they're sitting up. And using a spoon is good. They have all those crazy pouches now. So if you use a pouch, put it in a bowl, use a spoon, because a lot of kids are just sucking from the pouch. And using a spoon is teaching you speech and textures and all those things. Variety helps with later acceptance. Finger foods about 9 to 12 months. Strips of dry cereal, dry toast, strips of meat, soft vegetables, fruit, tofu. So first year we usually say cow's milk. GI has 3 times the amount of protein, high renal solute load, no iron, primary saturated fat. Limiting juice, water, kidneys cannot take hemodilution, and it's not necessary before 9 to 10 months. Increase calories, so if you have a child who is not taking in enough nutrition, or if the volume is limited, if they're on a fluid restriction, concentrating formulas can be a possibility. So your typical concentrated formula is 40 calories an ounce. We usually dilute it with water 1-to-1, and it makes a 20 calorie per ounce formula. Water formula is different in regards to amount of calories per gram and grams per household measurements. You might want to pay attention. Some will say packing like brown sugar. Most of them are not. You'll just kind of fill it and take the back of a knife. But increasing the concentration also increases osmolarity, tolerance, and fluid status. With our bang for the buck and concentrating formulas. So that I have seen, I've had kids in that are told to do Neosure because it's 22 cal per ounce, or a preemie formula. So you can concentrate any type of formula. So you don't want to use preemie formulas if the child was full term. So we can concentrate and manipulate those formulas as well. I've had kids getting human milk fortifier, so that's not appropriate at all. If the kids weren't premature, I think they can be on it. I am no NICU professional here. I think like 3.5 kilos, then that would not be appropriate. So using regular infant formula and adding less water with guidance. Is the whole measurements differ. So if kids are really, if it's really differed, some of your plastic cups and things like that will get bent and things like that. So if you're really having a tough time You might tell the parents to get a scale and measure out the actual powdered formula if that is necessary. So the modular things that we can use to add, so protein, carbohydrate, fat, and combination of macronutrients. So we might add like, in the hospital, we'll add like protein, we'll add Beneprotein, we might add Mojical for carbohydrate, Polycal, we might add corn oil, canola oil, MCT oil, so microlipid, different things that we can add as far as that goes. You're always there, if you can, to concentrate the formula because then you're getting a balance of vitamins, minerals, carbohydrates, protein, and fat. But if you're not able to, like my kiddo is on Alimentum 20, if I need to do something to it, I'm going to have to add something else to his feeds. Then enriching breast milk. So we do that all the time. You can mature or term formula to breast milk. I have a kiddo right now in the CTICU who is getting 150 mils per kilo, which is only 100 cows per kilo, not enough. So we need to talk to parents about adding a teaspoon of formula to 3 ounces of breast milk makes it about 24 cows an ounce. So it's a good way to bump the calories. Toddlers. So after 1 year, the growth rate slows down. Toddlers might not be as hungry. They're easily distracted. Their appetite is erratic. They get food jags. They're picky. So they might, at one for 2 weeks, love carrots. And all of a sudden, they won't touch a carrot. So just working to provide variety, giving choices, but also staying firm. I don't like parents being, short order cooks. So teaching kids, this is what you're served, this is what you're eating. We're not going to make chicken fingers and French fries for you because what kid wouldn't rather have that than broccoli? So teaching good eating habits, important. They'd be self-feeding, they're drinking from cup, keeping food on a spoon, and on self-feeding. So finger foods are ideal. Sometimes you can give a child a spoon, you have a spoon depending on their age, and you're kind of working together to eat. Obviously, it can be very messy, so patience. So parent concerns would be they have a limited number of food likes. But when I'm getting a history, if they're eating foods out of each group and doing a pretty good job, just slowly adding things is really important. Maybe they don't like meat. Maybe they won't eat vegetables. They want sweets. So, when you go to a restaurant now, what's on a kid's meal? Macaroni and cheese with French fries. Like, why have healthier food choices anymore for kids? So, and you're kind of abnormal. If kids want to pack healthy lunches now, it's like you're abnormal. People are going to make fun of you. It's kind of crazy. It's taking too long to eat if they're dawdling, playing with food. So that's why it's really important to get kids kind of on a schedule and knowing that their stomachs are small. Snacks are important, but healthier type of snacks. So I always recommend like 3 meals, 3 snacks per day. Sometimes it takes 10 to 15 tries to like new foods. So keep introducing them, keep showing them. That often helps. I usually use like the year per tablespoon rule. So I usually say like a 1-year-old if they're eating at least 1 tablespoon, 2-year-old, or I might say, oh, you're 2, you get 2 green beans, 2 bites, 2 this. So if they relate and they know what the rules are, they don't have to be part of the Clean Plate Club, but just making sure that they're trying it and having some. And, some kids will be eating and they know I'm not eating, but when I get up from the table, I'm going to get a snack. So no, if you don't eat your meal, then you're not getting a snack for dinner. And maybe later on, they'll get something that's more healthy. But, trust me, kids don't have appetite for dinner and then you see them walking around with ice cream cones and everything else. So just trying to balance. And it all fits, just trying to balance everything. So fostering healthy eating patterns, there's no good foods, there's no bad foods. You don't want to, put that into play. Being confident eaters, so knowing when they're full, knowing when they're hungry. Developing normal relationship with food. So just always being positive about food, body image, all that's very important. Nutritional needs. So nutrients of concern would be your calcium, your iron, zinc, magnesium, vitamins B6 and A. So always responsibility with feeds. So and Satter is wonderful. Caregiver's job is to offer the appropriate foods at regular times and model good table behavior. Just don't like vegetables doesn't mean you don't offer your kids vegetables. Trying to stay positive. It's the child's job to decide how much they're going to eat of what is offered and to decide whether they're going to eat or not. That's the choice. Do they have a job? Can they drive a car? Can they do anything? No. They figure out what they're going to eat and what they're not going to eat. are different book balance matter. But if kids do, with parents, you know, if the parents are real stressed about their kids eating, it kind of goes off on the children. So just being positive, letting them go to the grocery store, letting them pick out things, letting them help prepare the food, which is whatever age appropriate to them. A high chair or a seat at the table with the rest of the family is important. Too many kids are in front of the TV or they're walking around, they'll walk up to the table, they'll take a bite, they're just always on the go. Sit down, focus on what you're eating. Turn the TV off, no cell phones. And you want a role model that's worth imitating. So very important. Learn meals and snack times. Division of responsibility with feeding. No grazing. No force feeding. Likes and dislikes. Or favorite cup or bowl. Sometimes kids like their favorite superhero cup, and you'll get them to take their, you know, their drinks out of there. Avoiding using food as a bribe or threat. If you eat all that, you can have ice cream. We'll go to Dairy Queen. We'll do this and that. Try to make it a positive. This is just the dietary needs of a toddler. So 16 ounces of milk, 4-ounce serving size, whole milk until age 2. 1 cup of each fruit and vegetables, half to a quarter to a half is a serving, source of vitamin A and C. Usually they try to eat the colors of the rainbow. 3 servings of bread, cereals, and grains, 1/4 to 1/2 ounce serving size, at least 2 servings of whole grain a day. And then 2 to 3 servings of meat, fish, poultry, eggs, beans, tofu, have 1 ounce serving size. A lot of kids don't like to chew. They don't like to chew. So if you do eggs, peanut butter, beans, a lot of kids like things made in the crock pot that are kind of soft, so chicken and roast, putting beef and turkey and things like that with spaghetti sauce. So just different ways to get kids to try new foods. An example of a toddler menu. And hope tells the difference. My kids don't even know the difference anymore. You can buy that veggie pasta. It's all good. So avoid allowing too much milk or juice instead of eating. So a lot of kids, if they don't eat, they're drinking. So sometimes taking the cup away, trying to get them to eat first before offering beverages. Some people start foods too early, putting cereal in the bottle, try to get their kids to sleep later. Prolonged use of the bottle, midnight or nighttime feeding, and authoritarian, permissive, or neglectful style of parenting. And this is an example of nutrition for preschool children. And whole grain foods, chem-rich foods, fruits and vegetables are important, and then lean meats and poultry, baked, broiled, or grilled. All right, then. So oral nutrition be indicated. When oral feeds are suboptimal to meet nutrient needs, pediatric patients who have lost 10% or more of their usual body weight, or oral feeds are contraindicated over a significant period of time. So malnourished patients have poorer outcomes, more complications, more infections, use more resources. Obviously, kids are more susceptible to malnutrition and complications because they have higher nutrient needs and decreased nutrient stores. Oral nutrition. If the unwilling or unable to maintain nutrition by mouth, well-nourished infants and children with poor PO intake require nutrition support after 3 to 5 or 5 to 7 days. Malnourished infants and children within 48 hours of admission and must have a functional gut. I'm in the PICU, and we start kids on oral feeds within, aspirin will tell you within 24 to 48 hours, as long as the patient is stable, starting enteral nutrition is very, very important. It used to be kids would sit there for several days and not get nutrition, or maybe they would get parenteral nutrition off the, but now enteral nutrition is they're really, really good. Advantages: stimulates and preserves gut mucosa, reduces incidence of bacterial translocation, for metabolic infections and complications, improved hepatic function versus parenteral nutrition. It simplifies fluid and electrolyte management. It's a lot cheaper. Advantages would be delay in development of oral motor skill. I can say at Rainbow that our feeding team with speech and OT is absolutely amazing. We have kids that might not be able to take PO, but they're doing the whole oral motor development, which is very, very important. You have to have nutritive or non-nutritive oral stimulation. So contraindications would be a mechanical obstruction, liable route for enteral access. So if we have patients and there's no way to give them feeds, multiple trauma, congenital GI abnormalities, or malabsorption. So it could be mechanical, you could have metabolic, gastrointestinal, or infectious. So the thing is hang time, like especially in the hospital, our hang time is 4 hours. On the side, they have the spike bag so they can do their feeds for 48, but over in Rainbow, 4 hours is our limit. So obviously, if they're infant breast milk formula, 1 to 10 years old, we'll use like a 1 cal formula if needed. Greater than 10, typically a 1 cal, 1.5 or 2 cal per ml formula. So just our standard products would be like we have Nutrin Junior, our Boost Kit Essential, Pediatric, Complete Pediatric. Those are all formulas we'd use. If you want a protein hydrolysate, we have Peptamen Junior, Pediatric Peptide. Dental products, all your Neocates, Elacares, Vivanex, and then reduced calorie products, so the Complete Pediatric Reduced Cal, Pediatric Sidekicks, and then modulars would be like Duo Cal, which is a powder. It's a fat carbohydrate, has 25 calories per scoop. A lot of families will add that to foods or formula. Older, not infants, usually kids. Add calories. Benoprotein, the Nutrisource fiber. Some kids need MCT oil, Liquigen, or microlipid. Pediatric, it's a 1 cal or has a low calorie. It's been really beneficial for a lot of our special needs kids that don't need as many calories but still need the protein, vitamins, and minerals. We used to dilute formulas, and then you're adding all these things back to them. So that has been great, and it has real foods, missing a T on my ingredient. Chicken peas, carrots, tomatoes, cranberry juice. It's viewed as a formula by many families. Blood are becoming very, very popular. Homemade formula by blending foods into liquids. They should see a dietitian outpatient to make sure they're getting everything that they need. Cheaper, more variety, improved tolerance, reflux, constipation, diarrhea. I've had kids that are on elemental formulas, amino acid formulas. They go to their diet, or even the Complete Pediatric, and they do just with food. They do a whole lot better. Indications would be immunosuppressed patients. Do continuous feeds. You can with the other products, but not a blenderized home feed. You can't do, you have to be able to get bolus feeds. And you have a 14 French or larger G2. The P or blood feed. So whole food products, we're seeing a lot more kids come into the hospital on these products. So you have your Nourish products, have your real food blend. Farms has been really big lately. So they have standard formula, a peptide plus 1.5, and then a complete that are flavored. I know the peptide is the only one that's kosher and halal, because I had to look all this up, so there's your tidbit there. If you short-term delivery, you can use NG tubes for tube feeding, not for blenderized tube feeds. You can have OGs or NJ or NE, post-caloric feeds. Or permanent tube, obviously, if it's greater than 4 to 5 weeks. Might have a G tube, a GJ tube, or surgical jejunostomy. Feeding guidelines for continuous start, and then bolus feeds. So a lot of kids fed through the jejunum. You can't do bolus feeds, so they may be on cycled feeds. Some kids may not be able to tolerate bolus G-tube feeds. They might get like continuous feeds, like cycled feeds, so get a break in between hours a day. The price analysis on the different formulas, so your real food blends versus Nourish versus Complete versus Boost Kit Essential. Parental gamut. Nutrition is a hypertonic solution of water, dextrose, amino acids, vitamins, minerals, trace elements, and isotonic lipid emulsion. Just got a lovely email before coming over today. There's now a calcium gluconate shortage, so all the calcium has been taken out of our TPN. So there's always something. There's something. So we've had a aminosin shortage over at Rainbow for 3 years now. Everyone's getting trophamine. The trace element shortage a couple years ago. So this is last resort, because any shortages and just all the other risks and complications. So indicated if the GI tract is not functional or cannot be accessed, feeds providing an inadequate intake of nutrients, premature infants, patients with CHD, anomalies of the GI tract, neck, other GI conditions, critically ill patients receiving ECMO. So we have a kid that's been on ECMO for 30 days in the PICU right now and initially she was tolerating enteral feeds just fine. She was put on parenteral because they put her in a pentabarb coma. So then she's on nutrition. But otherwise, our kids in the PICU all get enteral feeds. It could be catheter-related sepsis, catheter exit site infection, catheter occlusion, if you have venous thrombosis, metabolic complications. Just monitoring very closely is very important. So you just want to make sure that you're getting like RFP and MAGs and just really monitoring their lab values and what's going on with them. So you have parenteral nutrition. So you have PPN, which is peripheral parenteral nutrition. So it's term use. It's limited in dextrose, 10%, 12.5% at the most. Risk of thrombophlebitis. The osmolarity needs to be 900 or less. And typically you're using, at Rainbow, we have everything per liter. So D10P22 is 100 grams of dextrose, 22 grams of protein per liter. PPN, total parenteral nutrition, is long-term, greater than 7 to 10 days, is administered through a central vein. PIC, Baroviac, Metaport would be examples. And the tip of the catheter needs to enter the vena cava. Would be dextrose, which 1 gram of dextrose is 3.4 cows per gram. Protein, like I said, we haven't had aminosin in a few years, so we have trophamine. It's acidic. It can higher concentrations of tyrosine and histidine, which are essential amino acids for young infants. You can put more calcium, not now, right? There's a shortage, but and phos. I didn't do the acidity, and 1 gram of protein is 4 calories. One of our fats is lipid, unable to use with an egg yolk allergy. It's a concentrated source of calories, so 1 gram is 10 calories. Source essential fatty acids, so you want to make sure that kids are getting 0.5 to 1 gram per kilo to prevent an essential fatty acid deficiency. It's got a low osmolality. So it's actually ideal for peripheral parenteral nutrition to help along the integrity of the peripheral. So a lot of people think, oh, they only have a peripheral and I can't do lipids, but it's actually ideal to do lipids. It gives them more calories because many times you're not meeting their calorie needs if they only have a peripheral line. Lipid is something that is pretty new for us. The 4-oil lipid emulsion, it's actually cheaper than intralipid, which I was surprised. So it's soybean, MCT, olive oil, fish oil, cows per ml. So I know in the NICU, if kids are going to be on parenteral nutrition greater than 28 days, they can get SMOC lipid. If we have kids whose bilies are rising, or if they have inflammation, or if they're critically ill, like we have a baby that came in with like a volvulus malrotation, he had surgery, he's going to be on CPN, we started him on SMOC. Big thing is after they're getting 1 gram per kilo, you typically want to run them. It has like a lower infusion rate, so you want to were you running them as long as the parenteral nutrition is running. So typically with like intralipid, we'll run them over 2 hours. With a SMOC, as we're over 1 gram per kilo, we run over 24 hours or the length of time parenteral nutrition is running. IV nutrient intake, parenteral calorie needs maybe 10 to 15% lower than the RDA for maintenance do. There's another typo. Reduce fecal losses and energy of digestion saved. Exceptions could include children requiring nutritional depletion with nutritional repletion or growth. Normally nourished kids after 5 days with suboptimal enteral nutrition, and then malnourished infants within 3 days, and malnourished patients within 1 to 3 days, or within 3 days of NPO is anticipated. The initiation of parenteral nutrition. Now over at Rainbow, we have a pharmacy. They make all the parenteral nutrition. We have to order it ideally by 2 o'clock every day, and they make it. The outside, they get their pre-made. So what they do when they're starting parenteral nutrition in adults is they'll start with a lower volume and slowly bump it up. With that, we figure out what their fluid needs are, and we'll do like a lower dextrose. So we'll start out with a lower dextrose level. Protein, if we have a central line, we can go for their protein needs on the first day. And then your fats usually start out slowly, 1 gram and going up to 3 grams per kilo per day, depending. As far as older nutritionists, so they're an outpatient registered dietitian. If they're in your hospital, finding an expert. If you go on the eatright.org, Academy of Nutrition and Dietetics, you can look up a nutritionist who is in your area. If you it would be CMH, but now it's CMH Children with Medical Handicaps. So if your kiddos are on CMH, then you can get a dietitian, go out to their home and do a home visit, and then they'll send you a copy of their report. Any child birth to age 5 who's WIC eligible can see a nutritionist at WIC. So just some ideas as far as that goes. Then as far as reliable nutrition resources, so the Academy of Nutrition and Dietetics is good. My lead is really good for like outpatient nutrition. I'll use that a lot for my home visits. The plate, there's lots of really good information on there. Like the GI Kids is good, Healthy Kids, American Heart Association, USDA, NASDAQ, and then if you you have access to the Nutrition Care Pediatric Manual, which is really good on the intranet. So and a lot of good resources. We also have the Aspen manual, pediatric manual that's on the intranet as well if you ever had to look anything up over there. So just some good resources. Any questions? No? Yes. When you have those questions, just make sure you're... Oh, okay. Okay. A question? Yes, Brandy. I mean, if they're premature, they need extra vitamin D and iron for sure. Or absorption, like CF patients need fast. So if there's nothing, if there's no other compounding factors, if a child eats a pretty well-balanced diet, you don't need to take a vitamin. And if you do give a vitamin, I would try to find a complete vitamin. So a lot of kids are taking those gummies now. And sometimes the dosage is 2 gummies. They might be taking 1 gummy. But sometimes they're really not complete. They're missing a lot of things in them. Flintstone Complete is a good multivitamin. Animal Parade is a good liquid multivitamin with minerals. A lot of kids use nanovitamins in the hospital. Aravite, Certivite, liquid multivitamins as well. So just depending, but just trying to find something that has everything is good. But well-balanced diet, eating well, I'd say no.
So kids that have autism and textural issues and they are resistant to food types, are you saying that these commercial whole food spots may be a good alternative, or what about the food in the pouches? Like you're recommend that?
As far as the tube feed goes, or just as far as food in pouches goes? So children with texture issues and things like that, hopefully they're working with like speech and OT. That's really important. I see a lot of families, the pouches, you mean if they'll only take it through a pouch? I guess sometimes in situations like that, however you get it in without force feeding and being positive is very important. I have kids that only eat certain colors of food, so maybe you have to do something to make the food that color. Or a lot of families, if the kids see a vegetable, they won't eat it, but sometimes they'll hide it in there. Like I'll have them put zucchini and carrots and pancakes, or be creative as far as that goes as well. But yeah, definitely, sometimes kids get into food jags, so only eat certain things, and you do what you can do. Sometimes putting something they're familiar with and putting something new, or when kids get into a situation where they're like in preschool, they'll eat better. It just depends when they're around other kids, or if they're someone they look up to and they see them eating it, they want to be like them. So
short term is okay.
Yeah, but I have a lot of kids. Like back in the day, there would be the I don't know what they were called. They were the things where you would the baby food in it, and they would like be sucking it through a tube. Fears, and they would suck it down. When you're doing things like that, you have no idea. Just like when you're starving and you're like eating, you have no idea when you're full. Just teaching using utensils and eat that way is good. No others? 6 minutes early. Is that up like that? Up.
We we have another break scheduled right now. It's just a short one because the next presenter is in 5 minutes. So just take a quick 5-minute bathroom break. There's more snacks that got delivered on the table, so eat some of that, and we'll see you back in 5.